Hello everyone, my name's Lewis Hodder. I'm an advanced care paramedic working out of Brisbane, Queensland, and today I'm going to be running through transcutaneous or transthoracic pacing. This is not to be confused with transvenous pacing, overdrive pacing, synchronized cardioversion or defibrillation, and all the other methods we have to utilize these pads.
TCP is a method where we use an external pacemaker via defibrillation pads to continuously shock the patient multiple times to take over the function of the pacemaker system of the heart because it has failed. How we measure the success is through mechanical features including heart rate, blood pressure and its surrogate MAP, as well as the patient's mentation.
So the reason that we do this is usually for bradycardias. It's either bradycardias that are refractory to atropine or pharmacological treatment, or bradycardias that are critically unstable and are likely to fall into asystole, as is the nature of this patient with a complete heart block.
It is contraindicated in asystole or PEA because it isn't effective in these rhythms. It is also contraindicated when doing overdrive pacing because of the proarrhythmic potential for that procedure. The other two considerations are hypothermia and drug toxicity, where pacing are probably likely to be ineffective. There are two key complications, pain, discomfort and anxiety being the first that we address with the reassurance and our fentanyl Mendazalem infusion, which we'll talk about later, and our failure to capture, which we'll talk about in the troubleshooting.
For the safety precautions for this scenario, we're going to have to wear a face mask, a mask with a filter, a gown, glasses and gloves, as well as adhering to the 5 moments of hand hygiene. For the purpose of this scenario, we will not be wearing all this equipment, however.
So the first step with our core pulse is to hit the pacer button to bring up our pacer menu. Here we have 3 different variables: intensity, mode and frequency. First we'll start with mode. So we have 3 different modes. We have the overdrive, so this is more for our tachyarrhythmias and overriding them. We also have our set fixed pacing, and that will deliver the set amount of impulses no matter what the patient's doing, and then demand, which changes the amount of impulses delivered depending on how many impulses the patient he or she is developing themselves, working with their intrinsic heart rate. We have intensity, so we can go to 10 and then 5 milliamp increments. We want to escalate this up to the point where we are finding capture, which we'll talk about later. The final component is frequency, and this is really just setting our heart rate, and usually 60 to 75 is usually sufficient for this. Here is a brief overview of the procedure that I'm going to go through today, including the pre-procedure phase, the procedure phase, and the post-procedural cares.
So with setting up our procedure, our first step is going to be reassurance to the patient. So obviously this is a pretty traumatic event. We're going to be shocking a patient through their chest with a number of amps over possibly a long period of time. We need to get the patient on board. We need to inform the patient of what's going to happen. And we need to ensure that we are giving adequate sedation and pain relief, which we'll talk about soon. We also need to prepare for arrest. This patient is critically unwell and unstable, first of all. In this case, they're at high risk of asystole. So we need to have suction, airway adjuncts, bag valve mask, pads applied, and ready to go with ongoing monitoring and very attentive clinicians. Next step will be getting an IV line flowing freely and fluids on board. This is an unstable patient, and hemodynamic support is of critical importance. As far as monitoring goes, we obviously need to have our ECGs on, our blood pressure being taken at regular intervals, not on the infusion line, and SpO2 attached as well to probably keep real-time monitoring of that pulse. We need to constantly be rechecking for a pulse, rest rate, conscious level status as well. We need to do a perfusion status assessment, respiratory status assessment, neurological status assessment. And that can often be offloaded probably to that circulation assistant if you are the single officer CCP. With our pad placement, as you can see here, we've got the red right arm pad between the 4th and 5th intercostal space at the lower third of the sternum. Behind the patient, you'll just have to take my word for it, we do have the lower left, or the left lateral pad, and that is just below the shoulder blade, quite proximal to the spine, just on the left of the spine area. In contrast to anterior lateral, which can be used if that's not possible, but this is preferred. The reason this is preferred is it decreases the level of impedance. The reality is there's just less tissue between this pad and the posterior pad, in contrast to anterior lateral. And the reality is, if we have anterior lateral, we're probably going to need increased amplitude to get the same result. The other thing is that we're going to involve a lot more skeletal muscle, a lot more trauma, and a lot more pain for the patient. We need to also ensure with our procedural sedation that we're going through our sedation checklist, and a lot of that preparation is involved there. Because there are risks obviously associated with administering, in this case, as I'm going to advocate for, Mendazalem and Fentanyl.
This is the perfect segue into my justification for Mendazalem and Fentanyl. When talking about sedation, it's important to talk about our goals. And I think this diagram, this hierarchy that's used in anesthetics is a fantastic representation of what we're trying to achieve. We have to remember that keeping a patient alive and preventing physiological compromise are the most important things. However, the combination of Mendazalem and Fentanyl together do achieve those top 3 items, which are the least important. A lack of memory, pain and awareness is crucial, however, when pacing a patient, because it is quite distressing for both. I would advocate for an infusion to maintain a serum level within an equilibrium that provides a therapeutic effect and decreasing the chance of undersedation of a patient who's going to be frankly traumatized by your treatment. An infusion may prevent an overdose in these patients and adverse effects, including hemodynamic compromise in a very brittle patient also.
What are our measures of success? So when we're looking at this pad placement, we're looking for 2 measures of success. The first one is electrical. We're looking for that pacing spike, QRS, and then T-wave. We also need the mechanical, however, because if we don't have a mechanical output, then there's no point to our procedure. We care more about the mechanics than we do probably the electricity. So that's a really important consideration.
To determine a bit further our measures of success, I've included this list. A holistic ECG interpretation, taking account for the T-wave, is very important. A continuous pulse assessment and continuous hemodynamic assessment, including a perfusion status assessment, is crucial. Level of consciousness due to increasing stimulus, QRS due to phantom QRSs, and pulse due to the difficulty in palpating a pulse in an unstable patient can all be misleading. Assuming we have met our goals for adequate sedation, or the patient has become so compromised that we believe we need to move to pacing straight away, let's move to the procedure itself.
As far as our procedure is concerned, we'll go to the pacer, placement in situ, and we have these 3 modes that we talked about previously with intensity, frequency, and mode. We're obviously using demand mode, as we talked about, and with our intensity, we're going to work our way up. Because this is a conscious patient that we're going to procedurally sedate, we'll work our way up. If it was a GCS3 patient who had a ventricular standstill, for example, we'd probably work our way down from 150 milliamps and then get to the lowest point that we could, and then probably increase by 10. And again, we obviously know our measures of success. So the moment we increase this intensity to 10, it will automatically start pacing this patient. And as we go up and through, we may find it at an intensity of 50 that we're getting a pacing spike through the patient, generating, as we have pacing spikes here, a QRS and T-wave complex. At that point, we're going to move 10 above. We need to be constantly reassessing this patient now we've established our intensity. We need to ensure that they're adequately sedated as well, and there's enough pain relief and sedation on board. Once we have an intensity of 60, say, we need to constantly be reassessing that pulse, constantly reassessing that blood pressure, ensuring that our patient is getting both mechanical and electrical conduction through. And we'll obviously be printing out this ECG to do a double check as well, to ensure that we do have a measure of success. As far as treatment options for this patient, we have a patient here who's in a complete heart block. This patient's probably going to need a pacemaker. Going through to a facility with cardiothoracic considerations is probably advisable.
Our 2 most common causes of failure is our pad placement or inadequate amplitude in our intensity. So adjusting these is key. We need to think about some of the complications as well. Obese patients have a larger level of impedance and failure is more common. You need to be very cognizant of a failure to capture or a pseudo capture where you have a phantom QRS with no large T-wave. You need to confirm with a pulse and with those abnormal repolarized T-waves, similar to a bundle branch block in the wrong trajectory to the QRS. The electrical impulse may also increase the level of consciousness of your patient and may not necessarily indicate a return of circulation or adequate circulation. This instructional video on transcutaneous pacing has been informative. Thank you for taking the time.